Hello, everyone. Thank you for joining. It's great to be here with you today and discuss how we can work to understand the global burden of cancer and leverage global burden of disease study or GBD study estimates to improve cancer outcomes around the world. My name is Lisa Force, and I'm an assistant professor at the University of Washington's Institute for Health Metrics and Evaluation, where I lead cancer modeling for the GBD study. And with me today are some wonderful panelists who I'll introduce in more detail when we get to that part of our discussion. For our time together, we'll begin by presenting the Global Burden of Disease or GBD study, share some of the GBD 2023 cancer estimates as well as GBD resources, then move to a panel discussion where panelists will describe how GBD estimates have been used to improve cancer outcomes globally, regionally, and nationally around the world. And then they'll also share how they've successfully translated GBD estimates into action. And then we'll wrap up by answering some audience questions. Before diving into the GBD study itself, I think it's valuable to consider why the GBD study was established. We know that observed data are really crucial, and true epidemiologic differences, of course, in cancer differ around the world. Unfortunately, though, when we think about one of the largest data sources for assessing cancer burden, population-based cancer registries, there are large data voids, and the data that does exist can be incomplete or can have challenges with data quality. This map is from a recent article that assessed population-based cancer registry coverage using cancer incidence in 5 continents data, with the white areas being where there is no cancer registry included in that data set. And similar gaps exist for other data sources like vital registration systems. So without data in some locations, this can imply an absence of burden from cancer at a country or regional policymaking level, which is, of course, misleading and can lead to an underprioritization of cancer policies relative to other diseases. And it can also create challenges in more broadly comparing cancer burden across countries and setting targets at a global or a regional level. So, how can we fill in these white gaps and ensure comparability between countries? That leads us to the GBD or Global Burden of Disease study. A core GBD belief is that everyone deserves to live a long life in full health. And there's a recognition that you can't save lives if you don't know what people are dying from. And you can't make people healthier if you don't know what ails them. So, to improve health outcomes, you need health metrics that are both comprehensive and comparable. And the GBD study aims to do this. It's a systematic scientific effort to quantify the comparative magnitude of health loss from all major diseases, injuries, and risk factors by age, sex, location, and over time. It estimates a mutually exclusive and collectively exhaustive list of causes of health loss and produces results that are internally consistent. This integrated analytic system is important to ensure that there isn't double counting of deaths by different organizations that focus on individual diseases, which was a challenge historically in global health. Strength of evidence is communicated through uncertainty intervals for each measure that's estimated, and we continually work to identify and incorporate new data. The GBD study also recognizes that models are never perfect, and with each round, data and methods are updated, so each round's estimate supersedes the prior round's estimates. In terms of dimensions estimated, the GBD study estimates burden at global, regional, national, and select subnational levels for 5-year age groups, as well as more specific or aggregate age groups for males, females, and both sexes combined for the years 1990 through the most recent GBD round year, which is currently 2023. And then finally, estimates are provided for 375 diseases and injuries, which include 50 different cancer types or groupings and 88 risk factors. The general GBD cancer estimation inputs and outputs are shown here. Data sources include population-based cancer registries, vital registration systems, and verbal autopsies. Using these data sources, we model and report cancer incidence, mortality, prevalence, years of life lost, or YLLs, which is the premature mortality due to a cancer, years lived with disability, or YLDs, which is the time lived in less than ideal health from undergoing, cancer treatment and its sequela, for instance. And then finally, disability adjusted life years, or DALYs, which are the healthy life years lost due to a cancer. And these are all produced for every given age, sex, year, and location that are estimated for the 50 different cancer types or groupings that we estimate. And then they're presented with 95% uncertainty intervals. To inform global cancer control efforts, we use GBD 2023 results to analyze cancer burden globally and by World Bank income group. And we found that cancer was the second leading cause of death globally in 2023 after cardiovascular diseases, which you can see here in this second row with the red arrow. And over 18 million cancer cases were estimated to occur in 2023, with over 10 million deaths. And these are large numbers, and it's important to take a step back and remember that each of these numbers were individuals who lost their lives, which can sometimes be hard to conceptualize among the sheer volume of the burden. This figure also shows how the relative cancer mortality compared to other diseases in 2023 across World Bank income groups. And you can see that cancer ranked among the top three causes of age standardized mortality rates in all World Bank income groups, even in lower income countries where communicable disease burden is higher. Cancer is really no longer a disease of high income countries alone, underscoring that it needs to be considered as part of health service planning in all settings. As part of our analysis, we also estimated that over 40% of cancer deaths were risk attributable. You can see in the figure here on the x-axis risk attributable cancer deaths for both sexes combined, and on the y-axis the various risk factors that are estimated, listed from top to bottom in terms of greatest to least risk attributable cancer burden in 2023, with tobacco and dietary risk factors being the greatest contributors to cancer burden. And this percentage suggests that addressing cancer risk factors is an important component of cancer control and an opportunity to mitigate future cancer burden, which will require both individual and policy population level approaches to reduce exposure to known risk factors. Importantly, the substantial proportion of cancer deaths that are not estimated to be risk attributable also highlights the need for strong health systems that address the entire cancer control continuum, from ensuring access to early diagnosis and effective treatment, survivorship, and palliative care, alongside risk reduction efforts. An intensification of risk reduction strategies may be helpful for reducing cancer cases in the future compared to what the currently estimated trajectory is, but there are people who will continue to develop cancer now and in the future who will need access to quality diagnosis and treatment. When we assessed cancer burden over the last several decades, we noted that the number of cancer cases and deaths were estimated to have increased globally and in all World Bank income groups, as you can see in the red boxes here, with the greatest percentage increases in lower, middle, and low income countries. This table has incidence, mortality, and DALYs listed in the rows, and then the columns are locations, so global, and then by World Bank income groups. And you can see that the number of new cancer cases globally more than doubled between 1990 and 2023, while the number of cancer deaths increased by about 74%, with the majority of those cancer cases and deaths being in low and middle income countries. We also noted that while age standardized mortality rates declined globally, which is great, and you can see here in the blue box, this was driven by declines in high and upper middle income countries, while lower middle and low income countries did not see those same declines in age standardized mortality rates. So while the age standardized mortality rates declined from 1990 to 2023, we estimated that those changes would be insufficient to meet the UN Sustainable Development Goal target. As many of you know, the UN SDG 3.4 aims for a one-third reduction in premature mortality from non-communicable diseases, which include cancers, between 2015 and 2030. We estimated the cancer-specific progress towards this goal, forecasting a relative decrease of only 6.5%, suggesting that an intensification of efforts addressing cancer burden is going to be needed to meet this target. Finally, we forecasted cancer burden in the future through 2050 and found that the reference forecasts, aka the most likely future scenarios, suggest that without additional action, over 30 million people will develop cancer in 2050 and over 18 million will die from it. We estimated that over half of new cases and two-thirds of deaths would occur in low and middle income countries. We also estimated that H&R's mortality rates are not forecast to increase, implying that most of these new cases and deaths would be due to demographic changes. However, I think it's still quite important to know about this increase in cancer cases and deaths so that countries can be aware and ensure that there's appropriate health service preparation and planning to care for those that are going to need it. I do want to share some limitations to keep in mind about our analysis of GBD 2023 results. First, while we aim to use the best available data possible, there are data limitations, particularly in low and middle income countries. So it's important to note that these are estimates and not directly observed data and should be interpreted with that in mind, as well as considering uncertainty intervals. GBD estimates do not replace the need for directly observed data. In fact, models rely on observed data, and building cancer data surveillance systems is going to be really crucial to ensuring sustainable improvements in cancer outcomes. Second, the GBD 2023 estimates did not include several infectious diseases as risk factors for cancers, which likely underestimates the risk attributable burden in low and middle income countries. And then finally, our estimates of future cancer burden can't account for the impact of potential new breakthrough discoveries that could alter the trajectory of cancer burden in the future. So, in summary, cancer remains a major contributor to global disease burden. Progress in cancer mortality globally is inequitable and driven by declining rates in countries that have greater income. Cancer cases and deaths are anticipated to grow substantially over the coming decades, with disproportionate growth in countries that have lower income. And all of this together suggests that greater action is needed. Cancer control policies and implementation have historically been under-prioritized in global health, and there's insufficient funding to address this challenge in many countries. So it's great that there's going to be a panel discussion talking more about cancer financing at London Global Cancer Week tomorrow. Finally, GBD estimates can help support governments and others in the global health community in developing policies and interventions to improve cancer outcomes. And we'll be hearing from our panel soon on how they've leveraged GBD cancer estimates as part of broader policy and resource planning efforts. GBD estimates are provided as a global public good, and there are several tools online that you can access to find results in a myriad of combinations. This is a screenshot of the GBD results tool, and you can see on the left that you can select the type of estimate you're looking for, including the measure, metric, cause, location, age, sex, and year, and then have a table of results generated here on the right that you can download and use. And note that you can select total cancers with and without non-melanoma skin cancers or various cancer types. Here we've just selected breast cancer. You could select any of the countries that we estimate. Here is Ethiopia as just one example. GBD also has visualization tools online that you can use to present results in a variety of ways. I've shared a few examples here, but would encourage you to explore these online tools and see for yourself the diversity of figures that are available. It's important to acknowledge the GBD study is a global effort, and the GBD Collaborator Network currently has made up of over 18,000 individuals around the world, nearly 2,000 of which have cancer expertise. And we gain really invaluable insight and feedback from collaborators on local estimates and context. And they help us generate the best estimates that we possibly can each round. And collaborators lead many of our publications and have access to additional GPD training and tools. And we welcome collaboration. So if you're interested in learning more, would encourage you to check out the website listed here. I've consolidated some important links in this slide, and I'll just note that the IHME website and GBD visualizations also have more information about other IHME endeavors, including estimating healthcare access and quality or assessing funding streams around the world for global health, et cetera. So worth checking out. And now we'll transition to the panel part of our discussion together today. Each of our five panelists will briefly present about how they have used GBD cancer estimates in their work to create positive change. And then we'll have time for a discussion with the panelists. We'll begin with panelists with more of a global focus to their work and then move to panelists that have more of a local focus. First, we have Dr. David Watkins joining us, who's an associate professor in the departments of medicine and global health at the University of Washington and is a PI and series editor of the Disease Control Priorities Project. He studies health system reform and policy implementation with a focus on non-communicable diseases and has served on numerous international commissions, advisory groups, and task forces around the use of data for policy development. He's also a GBD collaborator who's co-authored several GBD papers over the last 10 years. So thank you for being with us here today, David.
Thanks very much, Lisa. I'll talk briefly about how we use GBD data to support priority setting in cancer. And by priority setting, I mean, how do we choose how to allocate resources in a limited resource setting to respond most efficiently to rising cancer burden? The group that I work with is called the Disease Control Priorities Project. It's an enterprise that's been around for about 35 years now. And its focus initially started in the World Bank was to support countries to identify high value for money interventions in low and middle income countries. The work has been published in a series of books by the World Bank and has spawned its own enterprise. And many people would argue the IHME and the GBD is one of the outgrowths of the original DCP World Development Report in 1993. So it's a very influential project. What I'm going to show you today is a project we've been working on within the Disease Control Priorities Project called the Fair Choices DCP Analytics Tool. Fair Choices refers to the fact that we want to try to make fair and efficient choices on the path to achieving universal health coverage, and fair means an attention to equity as well as efficiency. So what we do in this modeling tool is to identify cost-effective health interventions in different country settings, but also to bring in other considerations such as equity across interventions, financial risk protection, which is especially important for things like cancer, and other criteria that you might choose to prioritize various interventions. And mostly what this tool is used for is for health benefits package design, although it has some disease-specific applications as well. The tool does costing of intervention scale-up scenarios where you identify a selected set of interventions, produces incremental cost effectiveness estimates as well for debating which interventions to cover through UHC systems. And importantly to today's topic, the epidemiological demographic modeling part of the tool uses to estimate intervention impact, uses GBD fatal and non-fatal estimates of cancer and other conditions as well within one integrated modeling platform. As I mentioned, this is mostly a tool that's used to support country national governments or subnational governments in benefit package design. Right now, we have support from the Norwegian Agency for Research for Development Cooperation for doing this work in about 4 or 5 countries over the next several years, with other country opportunities to engage as well. And the Disease Control Priorities Project is a series of books that's released occasionally by the World Bank. We're working on a 4th edition of DCP called DCP4 that's coming up soon. At the bottom is a reference to a capstone paper from DCP3 on cancer that you can look at, and the website for DCP4 and the ongoing work there. Next slide, please. I'm just going to show you a few screenshots of the tool so you can get a sense for how these data are being used at a high level. The website below, if you're interested, is fairchoices.org, and you see it's this landing page where you can launch the tool, or at the top, find out more about how it works and the other education and capacity building work we do. Next slide. Once you go into the tool, you select a country, and it auto-populates all the country's default data, which come from GBD. So cancer incidence, prevalence, mortality, all-cause mortality, deaths and cases of other conditions, things like that, disability weights and everything to calculate deaths and healthy life years projected over time under different intervention scenarios. And what this is showing is that if you select maybe a package of 5 or 6 cancer interventions and then run that, you can get some results and to get a sense for how much this would impact your health budget, but also what are the health gains you might achieve. Next slide. And you could see some of the readouts for this, stylized package of, what is that, about 7 cancer interventions, where you see projected deaths averted over time, mostly from cervical cancer and oral cancer in this particular scenario, and then projected costs. And most of the cost of this package are from screening for breast and colorectal cancer. So it gives you insights into what's driving budgets as well as mortality changes. Next slide. We've done a lot of work with this tool already, and as I mentioned, it's been used and is being used in national policymaking processes in several countries. And we're very happy with that. There are, of course, opportunities to continue improving what we're doing. With regard to using GBD data, as Lisa mentioned, you get estimates of incidence and prevalence and mortality from cancer. When you're designing cancer models, you still have to figure out the middle space. And so what we work on, particularly in countries with limited data on, stage specific, disease outcomes is, calibration methods that help fit to that. And so that's one area where we're trying to improve, particularly for countries with limited data. Although GBD is a great advance in terms of, getting causes of death and disability for cancer more specific, there still need to be even more specific. And so we're working on trying to split GBD causes in a coherent way to look at sort of subtypes of cancer and whatnot. And then, of course, integration of local cancer registry data and other sources of data, which is what countries really want to do. They want to see their data being featured. So these are some opportunities for improving the tool in the future. But I would say that what we've done so far wouldn't be possible without, the excellent data and timely data that IHME produces through GBD. Thanks.
Thanks very much, David. And next we have Dr. Nikhil Bhakta, who's an associate professor in the departments of Global Pediatric Medicine, Epidemiology and Cancer Control and Oncology at St. Jude Children's Research Hospital. Thanks for being with us here today, Dr. Nikhil.
Yeah, thanks, Lisa. So it's rare that at these kinds of events we get to talk about childhood cancer. So we can kind of just start at the top. And so we really can't think about how we are addressing global childhood cancer control without really highlighting the work being done by the WHO in association with St. Jude and many other partners through the Global Initiative for Childhood Cancer. This was launched about 7 years ago at the UN General Assembly as part of an event next. And you can click next twice, probably. And out of this initiative, the initial goal and indicator was that by 2030, we would increase survival from what was estimated at the time to be about 30% to 60% 5-year survival for all children globally, and also make an attempt to improve access to palliative care to reduce suffering for all children, including those with incurable diseases. Next. And of course, one of the challenges, of course, with this is that we're setting these targets. We're also doing kind of back of the envelope calculations, identifying that perhaps this will lead to about 1 million more children saved. And so this really set us on a pathway to really recognize that we needed to have better data. At that time, there was limited information out there. And so if you click next twice. Through the work done by the WHO, we developed the cure-all package, which is really the technical package to governments. And this has led us to really work collaboratively with over now 76 countries around the world to integrate in childhood cancer and identify these targets as goals for their health policy making. The reason why all of this is relevant is as we were generating those initial estimates, as we were generating those initial figures and indicators, a lot of that was based on just the simple estimates that were available at that time with GBD, but they also helped us identify in those early days where there were opportunities to collaborate with GBD and with Lisa's team in order to further do much of the work work that David is talking about, to do some more splitting, to identify different subtypes, and to take the number of uncategorized cancers, which were 70%, which were only about 70% categorized, 30% uncategorized, meaning that there were 30% of childhood cancers that really just went into an other category, and work now to have that reduced to around 10%. So that gives us much more precision in our estimates as we're working with governments around the world. Next slide. And so how have we used these data? I think you'll hear similar themes to as David highlighted. Again, in the early days, as when we started as we were just launching the Global Initiative for Childhood Cancer, we were also working together with many partners around the world on this Lancet Oncology Commission for Sustainable Care. And one of the key elements to come out of this commission was a return on investment case, that really, how much is it going to cost at governments, and how do we actually start to, what interventions do we need to implement? And so we did a very crude model, but in order to do that, we obviously had to have basic epidemiologic data. And so this entire model, the underpinnings of it in terms of the epidemiologic components are based on GBD data, because GBD was the only one that gave us disaggregated data, for example, on ALL versus AML at the time. And so these allowed us to gain several important insights, which then have gone on to really highlight and impact the GICC. First and foremost, that no single intervention is going to necessarily get us to the goal targets that we would have. And really, there was a potentiation effect between interventions, between access, abandonment, amelioration, and increasing treatment. And so you can't just do one, you have to do all of them together. And then secondly, that there was a significant productivity gain against those treatments. Next. And so that output directly related to outcomes from the GBD has spurred, I think, that what you see now, that interest in governments to really invest in their childhood cancer services as part of the output from that data. Next slide. But then, as we started to delve into interventions there, specifically then looking at treatment, one of the key challenges that we've seen in the childhood cancer space, where prevention is not an intervention that we can work on for children with cancer, because you can't prevent childhood cancers, you can only treat them. Access to medicines was a key issue. And of course, childhood cancers is not singular, but it's multiple cancers. And so you need to have multiple different drugs and multiple different formulations in order to be able to address the burden. And most of the time, in many countries, they're either lacking access to those drugs, or there are major stockouts that can persist for months. And so St. Jude, together with the WHO, partnered in order to launch this global platform for access for childhood cancer meds, with St. Jude investing over $200 million into this over the next 5 years, and partnering with WHO, UNICEF, and PAHO to deliver those. Drugs are already flowing into the first 6 pilot countries, and the next 6 countries, as part of this pilot process, are working towards getting their drugs early next year, with the goal of treating 120,000 children in 50 countries through this pool procurement and health system strengthening platform. Now, why is GBD relevant here? Obviously, before St. Jude was willing to make this level of a commitment, we had to understand what was the market potential of this, and what was that investment going to look like in order to actually reach those children. And so all of the data that we had to do, that obviously incorporated a lot of the forecasting materials that we created for drugs, all required us to understand data from the basic epidemiology, and the only real data that, again, parses it out in a definitive way with enough precision, in terms of the different subcategories, like again, ALL, AML, but also neuroblastoma and other subtypes of childhood cancers that are not routinely estimated through ICD-10, was the GBD. Next slide. And then, yeah, perfect. Go ahead.
Thanks very much, Nikhil. Next, we have Dr. Siti Nadia Tarmizi. Uh, she is a director of non-communicable diseases, at the Ministry of Health of the Republic of Indonesia. Thank you so much for joining us so late your time to share how Indonesia has used GBD estimates in addressing NCD burden.
Yeah, thank you, Lisa, for giving us the opportunity to share regarding the data GDD that we'll use in our country. Okay, so please, like mentioned by the previous speaker, that we know Indonesia still have a double burden in terms of communicable disease and non-communicable disease. And then with the data that IHME metric provide us, GBD data, So we know what will be the next we should do to prioritize the disease. We can see here beside the communicable disease, the cardiovascular disease, and then if we see the projection in 2023, the number of neoplasm is very increased. I think in 1990 is our rank 7, and now it's become the second one. Next slide, please. So if you see here, we are working with the IHME to provide the data in terms of cancer. And then we are able to retrieve the data that the cause of the leading cancer in Indonesia are, the first one is the lung cancer, the second one is the colorectal cancer, and then the third one is the breast cancer. And GBT cancer data, it can be accessed and download for all 36 provinces. Previously, I think we don't have this kind of the data. The data for cancer is only available at the hospital level. So with the data that we have with the GBD, we are able to distribute to all the province. And then another thing is the data which include mortality, deaths, and the risk factor and other. Of course, with this data, we are able to understand the magnitude of the cancer burden in Indonesia. Next slide, please. And here, like I mentioned, it's not only the numbers and the rank of the cancer data, but for the palliative care, we got the information from the data regarding the quality of life indicators, which include dailies, yearly dailies, and yearless life. And you can see here the which of the cancer will affect on dailies, and then with year life disabled can see how is the impact on the cancer and the palliative treatment program. Next slide, please. And then we are able again distribute the number of cases with the 5 top ranks cancer based on the data GBD across the 36 provinces in Indonesia, and we are able to see the distribution by age, and then we can see which the highest age group that affect with these 5 cancer. Next slide, please. And with the projection, we can see the mortality and disability up to 2050, which means that if we don't have any intervention, especially on the preventive care or the early detection and early diagnosis, it will be a very big burden and a big number for Indonesia in 2050. And of course, it will be economic and health issue for Indonesia. So with this kind of the projection, we know and we can really have the numbers that if we would like to have the intervention, we can reduce the number by 2050. Next slide, please. Yeah. So this is, in conclusion, what will be the GBD data is really supporting our policy making for Indonesia. The first one is we are identified and priority all health challenges, including that we use GBD data to identify the leading cause of the premature death, year of life loss, and the years life with disability in Indonesia. And we can prioritize beside the cardiovascular, and then we have the cancer, and then within the cancer we have ranked the top ranked cancer in Indonesia. And then, of course, we have like develop evidence-based intervention between by 2050. If we don't have any prevention, early diagnosis, early detection, we will have a very big burden in terms of economic and health issue. So now we have a program. We can say that we call it the free health checkup for every Indonesian citizen in order to have the prevention program. And then we have the tools that can monitor the intervention So we have a health system improvement, and then we can see if there is health disparities. And then, of course, we can have a special intervention if some provinces are lag behind another provinces. And of course, with this, we can bring the research and the public health into one system. I think that's my last slide, Lisa. Over to you. Thank you very much. Oh, yeah. Based on that situation, we developed the NCCP for cancer plan in Indonesia. Okay, I will stop here, Lisa. And
Okay, sounds wonderful. Thank you very much, Dr. Nadia. We very much appreciate your time being with us today. Next, we have Dr. Flavia Gerardi. She is a medical expert at the Federal Department of Medical Expertise and of the Ministry of Social Security in Brazil. And thank you for joining us today, Dr. Flavia, to share how our Brazil collaborators have used GBD estimates.
Thank you, Lisa. Thank you, everyone. Thank you for this opportunity to talk a little bit about Brazil. So I'm going to give you just a brief presentation of two topics. The first one is the Brazilian Plan for Controlling Chronic Diseases, and the second one is the asbestos situation in Brazil. Next, Lisa, please. What I'm showing here is just part of the plan for controlling chronic diseases in Brazil. You have made some other estimates on risk factors, but not using GBD data. So we used GBD 2019 to analyze trends in chronic diseases, but talking specifically about cancer, we used GBD estimates on breast cancer, cervical, and colorectal cancer, and use it as an indicator the premature mortality, which means mortality from 30 to 69 years old. So you can see in the graph our targets in the follow-up. The orange dotted lines show the forecast, the forecasts were based on the GBD estimates, and the gray dotted lines show the targets. It seems that for breast cancer and colorectal cancer, we are going to meet the targets. The thing is, the GBD estimates has helped us a lot to monitor screening programs. You have already screening cancer programs for breast and cervical cancer in our public health system, and we hope that GBD can help us to introduce a screening for colorectal cancer as well in our public system. Next one, Lisa, please. Now I'm talking very briefly again about the asbestos situation in Brazil. But first of all, it's important to say that asbestos-related diseases data in Brazil are very scarce. So, of course, you have some data on mesothelioma, but when it comes to lung cancer, ovarian, and laryngeal cancer, data are very scarce. So the GBD data plays a very helpful role in analyzing mortality and burden. So we used GBD 2019 to analyze lung cancer, trends in lung cancer related to asbestos in Brazil. And we had some increasing trends in the northeast of the country. Asbestos was banned in Brazil in 2017, but we still have mining activities in just one state of the country, Goiás, because we had some setbacks in legislations and we had a state law that provides the permission to keep extraction of asbestos in Goiás, only for exportation. Next one, Lisa, please. And again, we use it now GBD 2023 estimates to analyze trends in cancer. Now I'm talking about mesothelioma and ovarian, laryngeal, and lung cancer in the Americas. And now we could situate Brazil in the Americas. And again, we had some increasing trends, not only in Brazil, but also in other regions in South America in women, which is worrying. And finally, what do we expect for the future? Of course, we all expect the complete ban of asbestos in Brazil. But as I said, we have some strong commercial interests and many setbacks in legislation. So there is one state that keeps mining asbestos, and it's just one company in the state of Goiás that keeps mining asbestos for exportation. And this company claims it's just for exportation. But we have to bear in mind that we are exporting a risk, environmental risk. And it's not, you don't have exposure just in mine activities. We have exposures during transport, during manufacturing, and again, we have a legacy of asbestos in our country, and also in the US, in Canada, and we have exposures during demolition, during repairing activities. So this is a legacy, yes. And personally, I would like to see estimates on occupational asbestos. I believe that will be very helpful for mapping environmental contamination. Thank you, everyone.
Thank you very much, Flavia. And finally, we have Dr. Owoke Miskanal. He's collaborated with the Global Burden of Disease Study for over a decade. He's a clinical associate professor in the Department of Health Metric Sciences at the University of Washington and a senior advisor of Ethiopia's National Data Management and Analytics Center at the Ethiopian Public Health Institute. He leads Ethiopia's national and subnational burden of disease work and has integrated GBD evidence into policies and health strategies. He also co-leads the African Burden of Disease Collaborative Initiative within IHME and Africa CDC, and has overseen major national data system strengthening efforts, including piloting a sample registration system. So thank you very much for being with us here today to share your experience.
Thank you, Lisa. I'm sharing the experience that we had for the last 10 years, the institutional collaboration between IHME, Ethiopian Public Health Institute, and I think we have a very good experience on this area. Next slide, please. So because we started in 2016, 2017, we were able to have strong institutional collaboration and having subnational burden of disease, national burden of disease for Ethiopia, and we have a very good strong team at Ethiopian Public Health Institute, which I'm advisor for that, the National Data Management and Analytics Center. So these young, energetic experts who are closely working with the IHME Global Burden of Disease, they're currently well trained on data analysis, having the estimates and so on. So the policy impact of this global burden of disease estimates for NCD's cancer. Probably you may know that most of African countries we don't have such kind of data to inform policies and practice, and the same is true for Ethiopia, that we were able to inform the National Health Sector Strategic Plan, round 1, round 2, and also the current Health Sector Development Investment Plan, and the different packages, including the Essential Health Service Package, the insurance package, to the extent that in the NCDs, tobacco control, alcohol advertisement, we were able to provide these results for the parliamentarians to have some regulations and legislations in that direction. So from the global burden of disease, we were able to, understand at least, the leading NCDs, the leading cancer types, for the premature mortality, for the disability. And because we were also able to have subnational burden of disease, we were able to understand, the disparities between subnational states, so that, informing the Minister of Health, it's not just one strategic plan fitting for all, subnational states, urban, rural, because we're also having subnational, pastoralist communities. We are, having these estimates to support the ministry and subnational states as well. Next slide, please. So it's not only informing policy with the GBD evidence because of the collaboration, the institutional partnership we're having. We're able to secure, grants, different grants, including the Gates Foundation 2019 to 2024, 12 million project to establish a national data management and analytics center, and then to cascade that to the subnational states, the regional data management and analytics centers across 13, 14 subnational states, and to provide subnational burden of disease for Ethiopia. And systematically, we were able to analyze the data gaps that we are having in Ethiopia and initiating, sample registration system by Ethiopian Public Health Institute, just mobilizing, its government resources and other partners' resources. So it's also, supporting the evidence to decision making, discussions, dialogues, and all those things, and also, generating quality data in the future to support our subnational estimates. And the demand is high. Even the ministry is looking forward to have, district level burden of disease, because we have this district planning. So, we need to inform this district-based planning of the ministry having, more granular level burden of disease estimates. And this sample registration system that will have like more than 100 qabalis, the lowest administrative unit, could support, our estimates and also complement with the GBD estimates when it comes to cancer and NCDs. Next slide, please. So, the GBD estimate has been supporting our advocacy and also, stakeholder engagement. This is one of the picture that we are having Car-Free Sunday to advocate for walking, physical activities, and so on. And also, with this GBD, we triangulate the GBD estimates with other data sources. For example, the national health expenditure data, how much budget is, we are expending for NCDs and for other disease types. So is national expenditure based on or informed by, burden of disease or not? So this was very helpful to inform Minister of Health and to increase the cancer and the NCD budget by 25%. So, triangulating GBD estimates with other data sources also can inform the ministry and the partners for the resource mobilization, planning, and so on. Next slide. So there are future opportunities and, of course, lessons that we were able to learn. We have Addis Ababa Cancer Registry data that we are trying to compare GBD estimates with cancer registry and to validate some of the things and to monitor, the trends of this cancer, and also, advocating for this cancer registry to get scale up to the other subnational states, and of course strengthening this sample registration system initiative to have better data and use this GBD cancer projection to inform the economy, health investment planning, and others. So probably the most critical lesson that we learned is that for GBD, it needs, institutional partnership. So it's a kind of complementarity. It's a kind of opportunity to, mobilize, get some resources, funds to support, these resource poor settings like Ethiopia and other African countries to strengthen their data system, their data analytic capacity, health metrics capacity, and so on. And it's also important to have, subnational estimates. It's very important to have, to understand the disparity between subnational states and to have, targeted interventions, because, the national estimates are masking the disparity between these subnational states. And the capacity building is another lesson that, our team at Ethiopian Public Health Institute and subnational states were able to have, trainings and use of data for policy and practice. Next slide. I think this is the last. Yeah, thank you.
Thank you to all of our panelists for sharing your expertise and experience with us today. Our first panel question is, GBD has made a commitment to making estimates publicly available. What strategies have you found are most effective for integrating these publicly accessible results into your goals? What factors have contributed most to your success in doing so, and how have you overcome any challenges along the way? I wonder, okay, if you might kick us off with answering this question first, and then maybe Flavia or Nadia, you could follow up.
Yeah. Thank you. Thank you again, Lisa. Probably I can mention or emphasize three best practices from Ethiopia and Africa CDC perspective, and probably three barriers. As I mentioned, institutional partnership collaboration is very, very important to have, capacity building for Ethiopian Public Health Institute and also for IHME to understand, to have context knowledge about national and subnational burden of disease. And subnational estimates were very helpful as a best practice to understand the disparities, and also having or working with the team to translate estimates and to produce, actionable insights, evidence briefs, health policy briefs for the Minister of Health, and also to have, customized and based on national priority visualization tools. And maybe for the barriers, of course, the first to mention is limited local analytic capacity and data limitations and quality of data. That's a very big challenge. Of course, we are learning and trying to improve. And the second is staff capacity and the gap that we had, especially at the beginning of our partnership. And the third is the time lag between, the GBD estimates and the national planning. Now we are in 2025 and we are discussing on GBD 23. So especially this one, the national planning experts and decision makers are very key to see, updated estimates. So the time lag has a lot of implications with the national planning cycle. So I will stop here, Lisa. Thank you.
Thank you so much, Dr. Okay, that's very thoughtful answers. I don't know, Dr. Nadia or Dr. Flavia, if you might have anything else that you would like to share.
Yeah, sure.
Yeah.
I'm sorry.
Well, please, Flavia, please continue.
Thank you. Thank you. I guess, Lisa, in our opinion, one of the main barriers is a clear understanding of the methods that GBD use. So the GBD Brazil team has translated GBD basic course to Portuguese in 2019, if I'm not mistaken, which helped a lot. Not only Brazilian researchers, but also other Portuguese-speaking countries in Africa, besides Portugal, of course. And the course was also translated to Spanish in last year. So it helped. Thank you.
Wonderful. Thank you. Thank you very much. And Dr. Nadia, would you like to share your thoughts?
Yeah. I think first I would like say that anyway the GBD 2023 estimate is really helpful for the Indonesia, but of course there is some challenges. First, like for example, like many provinces they already have a cancer registry, which might different number that we came out with the GBD 23 data. And then we have, of course, data from our national health insurance that come maybe different things too. So I think what we say about how we the government to best integrate. Of course, I think this is the one that uh, really key things because in terms of integration, if the process of estimation of GBD data not only as much as the country have the local data. I mean that our surveillance data should be strengthening in terms of to provide the data for the analysis. So we have like a province data, we have like a mortality data, and we have some study from the university should be gathered and then to be the input for Indonesia GBT estimation. I think that's all.
Thank you for that's such insightful thoughts and feedback, I think that are really valuable. So thank you to the three of you for sharing that. I know we have limited time here, but I'm looking through some audience questions that have been shared. And one of them that I think is particularly pertinent in this current landscape. So, what mechanisms or collaborations do you believe are most effective in ensuring that GBD findings translate into sustained investments and implementation of cancer control programs, particularly in our current resource limited landscape? And I wonder if any of our panelists would like to speak a little bit more about that. I know, Dr. Awoke, you talked a little bit about some of the investment strategies that you all had used, but I wonder if others have thoughts too that they might want to add.
Yeah, thank you, Lisa. I think a kind of complementary approach between the GBD and the local institutes, that will be very important. And local ownership, very important. With the Ethiopian Public Health Institute, we have a burden of disease division. The institute has owned these national and subnational efforts like as part of its routine activities. And also kind of win-win. Win-win collaboration partnership could be very helpful because we need the local context knowledge and also we need the GBD advanced methodology and data processing and all the infrastructure. So I think this kind of more in a kind of trustful partnership and kind of complementary win-win partnership could be very helpful. This is how we build. We engage the decision makers, the Minister of Health policy makers, the minister himself, herself, and also the leadership, the Ethiopian Public Health Institute leadership. Now we are, one of the fourth wings of the Ethiopian Public Health Institute because we have a national data management and analytics center that considers the context and also addresses the frequent requests of the Minister of Health in terms of evidence demand, because GBD is not the only thing that the ministry and the partners are looking for. So that kind of integrated approach, more trustful kind of model could be very helpful to ensure national ownership and sustainable collaboration. Thank you.
I love that answer, Dr. Awoke. Very thoughtful and really, really critically important. I wonder if any of our other panelists have any other thoughts on that particular question before we transition to our wrap up.
I'm sure David also probably could speak to this as well, but I think exactly as Awoke mentioned, it's the transparency element of it, and also just finally uncovering what those costs look like. The reality is that, at least in the childhood cancer space, that costs are not incorporated in NCCPs, and as a result, they're not necessarily budgeted for or thought of in terms of what health system investments do need to come. So it becomes this kind of like you won't look for it, you don't see it, etc. So we, especially in settings where we don't have access to registry data, at least having the GBD as a starting point to break that cycle, to both advocate for health registry systems, but also to say investments are needed because this is not just a missing population, allows us to start that dialogue with ministries and with other stakeholders, which is critically important to beginning to break that cycle of essentially just like putting our blinders on and ignoring it.
Lisa, uh, uh,
Go ahead. Is it Dr. Flavia?
Nadia.
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 Sorry,
This is
my video was
just
off. Go ahead.
uh, just okay. Just adding what previous speaker already mentioned. I think we know the cancer previously based on the research on the university-based register and hospital register. So it's not really like a public health data. So now with the GBD data, we try to collaborate everything, integrate everything, and bringing the cancer issue from the clinical perspective to the public health perspective in order we can achieve and reducing the burden of the cancer. That's all. I think that's my comment. Thank you, Lisa.
Wonderful. Thank you very much. I'm going to just share our wrap-up slide here and say thank you to everyone for joining us today. The recording of this session will be available both on the IHME and the London Global Cancer Week website, as well as emailed to all of the registered participants. And we'd welcome any questions at the email address that's listed here. And we hope you all have a wonderful rest of your day. Thank you for joining us. Take care, and thank you for all that you do.
Thank you,
Thank you.
Lisa. Thank you, everyone.
Thank you.